everyone has used shockwave before, yeah. Yeah, so we have a couple of users for PiezoWave, but the rest they have used shockwave, but not this one.
Okay, so who has never used this one? So
we are expecting you're going to buy after this.
So like it's important that like you feel it because this feels so different from any other device. And that's the thing. So people who are existing users, I'll maybe answer some questions, but like you're already using it. So I don't know that there's anything new that I'll show you, but I can help problem solve through positioning or questions. So does anybody have anything they want specifically like to feel or?
لو في أي حد عنده أي شكوى بس أو أي حد عنده أي حاجة عايز يعالجها.
عندي مشكلة في التركيز.
طيب تعالى. لازم نعرف في لسه أو تأكيد صح؟ تركيز.
Yeah, we'll figure it out.
Yeah.
So like some heel pain or what is the problem? Plantar perfect. Okay. Good. So right now it hurts. Are you in pain right now or are you okay? Okay.
So you have a double injury.
Maybe we could put together these tables here. Maybe
we can
make a little
creative.
Yeah, maybe just be careful.
You want human
yes, take off your shoes. Just your shoe and sock on that side. Oh, what's that from?
Correct.
Oh,
This 2 days ago.
It's really fresh.
So I'm probably not going to treat that. The reason why you're probably having the plantar fascia problem now is because you're not getting the dorsiflexion because of all this. I don't think I'm feeling comfortable treating it. Just because you had an accident.
This is bilateral. Before the accident, I have a lot of plantar fascia, but it's increased on the left side since the accident.
Yeah. I still just.
But we can treat the
right
right.
on this side.
Yeah, we can do this side.
Sorry about that.
ده العربية تستعليق ولا إيه؟
أنا قاعد من فوق رجلي.
ألف سلامة.
So, one thing, so you guys has good big toe mobility. I mean, you know, I'll look at how stiff somebody's big toe is, because sometimes we need to treat through there. Pains, yeah. And I just want to check one other thing. Did you come over here? So here, can you take and touch me into this? Just to the side that's not hurt. Whatever. So what I'm looking for here is how much dorsiflexion he has. Once the heel comes up, then it's too much. So let's, because I want to try to figure out where is the tightness or the stiffness that we can work on. So I think let's pull right. Pull your pant. Will your pant leg come up?
Left or right?
The right side. Yeah, so we'll do that. So let's kind of lay on here, maybe
Wrong way.
yeah, pull it kind of here prone. But like 1 foot off the other. Yeah. Are you okay? Yes. So then, because we're working, I'm gonna treat both in the plantar fascia, but then we'll come up and do some treatment in the soleus as well. You okay?
Yes.
So I'm gonna keep my frequencies probably like 8. Yes. So a couple things, when we're cleaning of this in between patients is really important. If at a minimum, it should be done every day. I know we get into busy clinical practice and sometimes between patients doesn't get done, but every day we take everything apart, wash it with some cleaner, soap and water. And then you need to have a layer of gel in the base of the cup because the pressure wave cannot be transmitted through air, so you have to have gel.
Ali, how is it?
The dot is not apparent here, so I cannot see where.
You'll have the expert.
He seems to be the expert.
Yeah. You need to make sure, right?
So, yeah, I have to put a lot of gel because without it, there would be no shockwave transmitter. Excess.
Yeah. Again, we
It will work.
squirts out for his position. So it's in the groin. That it's hurting in the groin. In the groin. So yeah, this is without having it treated. So just go ahead and flip over. Just sit. Just sit. Just put that leg out straight. I'm sorry that this is not going well. So I'm going to start with the setting of about 5 to begin with. And so here, because I want to have a little bit of tension on the tissue, I'm going to bring the toe. Thank you. So we're starting this with a 5 out of 10, a 5 out of 20, sorry. And I'm going to scan around a couple different structures. You feeling that? You'll feel like a little bit of right around there. And it should feel like a little ache, kind of like a toothache.
Like lancinating.
More of a lancinating. About right there.
The origin of fish.
More down here. And if a 0 to 10, 0 is no pain, 10 is really bad. 4. Okay, so we'll leave it there. And so I'll kind of gently just move it around a little bit.
1.5.
Still 5. So I'll try to identify the painful point and then kind of move around just a little bit, and then I'll keep coming back to that sore spot. See if we made a difference.
You want to increase it? Power?
Just a little bit. Still about a 5. 3. It's going down. Good.
Increase one more.
Yeah, increase. So again, I mean, this is kind of like it's a real clinic situation in the sense that sometimes you can't put somebody in the optimal position because it's uncomfortable and you have to sort of problem solve. But if we're creative, we can still get through it. So while ideally I would have liked to have had him prone, we can still make it work. And we'll do the next one. I'll just have you slide forward. We'll do some stuff on sitting on the edge. How is that right now? Still out of 3. Still some there. So now we're kind of coming along. And I would say that we're probably actually a bit off of the plantar fascia and moving into some of the abductor hallucis. I hope it's not the pollicis. But again, why might we be getting a medial stress here? It could be coming, obviously, from some modifications to the accident, sure. But also looking at, hip activities, hip strength. There's other things that we could check because maybe there's some like collapsing and some stressing. It could be hip tightness as well. Some anterior hip flexors are tight. It's hard to test those things on the table. So let's move with this foot, and I'll have you just gently come forward and sit at the edge. All right. I'll do the foot in sitting. Let's finish this one. Just come forward. All right. So now, because we want to treat more than just. And let's bend this up. Keep a little bit long. Good.
Awesome.
You want to do something awkward. That's all right. No, I don't think this is the good. It's a shot. It's broken. Let's rotate this way. Perfect. All right. So.
Yeah, that's false.
So again, while this is less than ideal, we'll make it work. So I'm gonna take and just come in this lower leg. Ideally, I would like to treat the whole posterior chain. What's our setting?
7. Power 7.
Go to 10. And you know what, we're actually a little bit deeper. I probably would change out the gel pad here, but since this spring is not 100%, I don't want to mess with it.
You want to change what size?
I would probably go to a 15.
This is
No, this is a 5.
5?
This is a 5 here. Trying to see the number. Yeah, this is a 5. I would probably go to 15.
We are using 15 for the front of my
Yeah. So because it's you know, really close to the sole of the foot, I would a 5 or 10 prime mounts for me. Yeah, but because here I'm coming in, and you know, ideally I'd be wanting to come along and get flexor hallucis longus, soleus, posterior tibial tendon. I would probably want to go a little deeper, so I would use a 15.
Okay.
Are you feeling this thing? Yeah, I mean, I'd like to get up into the meat of the calf a bit more, but you know, here I could use my linear tool as well and get that. But the main thing is we try to get the ankle joint into mid-range as opposed to like a plantar flex or even really super dorsiflex position. You know, on the table, like my treatment table, I'm going to position them in prone so that their foot is on my thigh. So when I lean in, they get more dorsiflexion, plantar flexion, dorsiflexion, plantar flexion. So I can control the position of the lower leg as I'm using that linear tool and just really working the calf. I just don't trust these tables, and it's not pleasant, as you would identify. Go ahead and scoot back and I'll do your other heel. Set the put on the 5. And back. Zero it out. So again, I generally start at 5. If I'm not getting any response from any of the different points, I'll then go up another 5 to 10. And then if that's too much, I can always back it down. But I kind of want to get to where I'm eliciting some discomfort as quickly as possible.
So I'm asking the patient during the session about his pain during using that. But he told us that we started with low pain and then increased.
Sorry.
You told us during the session or the presentation with no pain, starting the session with no pain.
Yeah. Yeah. I mean, I started with low pain. He didn't feel anything, and then we bumped up to 10, and now he's feeling something. What's your pain level like?
كنا 10.
4. So then I could probably go up a little bit higher, but for the first session, yeah, I would probably like not make them too uncomfortable. But then generally, I want to try to get them up to a 6. So I'm first going to just see how he responds at the 4. If the 4 drops down to a 2 or a 3, then I'll nudge the number a little bit higher.
Make it high.
Mm-hmm.
It's normal if I have already the same There's a leading significant.
I mean, you know, there's not a whole lot that's normal considering you got some kind of injury and trauma there. So I don't know. I could be irritating the nerve. That's why I'm not super thrilled about doing this, but I'll do it. You know, if I'm over on this side, I'm going to get medium plantar nerve. I'm probably not going to have radiation over to the lateral throat as well. So
It's more osteotibial.
it's more what?
Osteotibial.
Yeah.
الوجع بيزيد ولا ايه؟
النقطة دي ازاي؟ Let's say
7.
هو الطبيعي ان during السيشن حتى لو على نفس البوينت الوجع بيقل شويه لان التوليرنس بيزيد مع الوقت يعني.
لازم احنا في الاول بنعتمد على السيرفر واحنا شغالين. التابلت كان بيبقى نازل كاستمايز نمبرز كده سواء في الفريكونسي او الانتنسيتي وشويه عالي عنها في البروتوكول شغالين.
ماشي، ما هو ده اللي في التابلت او البريسيت بروجرامز ده ريكومنديشن، انما هو individual يعني كل حاله انت بتسال المريض لازم تفضل you're asking about the protocols which is preset on the tablet.
The Innovation Hub website.
Yeah, but the most important, you have to be interactive with your patient. You need to ask,
Those are all
always
guidelines.
talk to him.
What's your pain?
it's lower here.
Okay. Scale. 0. Root. This.
Yeah.
Can you bump me up? Got it. Alright. Gotcha. How's that?
Go deeper.
I could go deeper by changing out the gel pads, although I'm pretty close. I think just increase the force that traffic.
كسر الدورين
Do
طرف.
you wear?
يعني right there.
Do you wear articulate or
ينفع الشغل
هيكلف جامد
كده كده احنا عارفين وهنقفل على طول. الكلام ده مش هياكل مع الدكتور مثال. We are talking about the number of chokers that we are seeing that the 2000, but in Egypt it's not working.
Yeah.
It costs a lot of money.
It's 3,000 or 3,100.
Yeah, I've hit a couple spots. I'm just doing this one a little more.
بس هنا هو يا باشا هو ايه لا بقول انت ماشي
How was that? Try it. Go ahead and
Is this?
Yeah.
I will try this.
Can you just take a few steps?
It's multi-factor pain.
I think the more benefit you'll get a little bit, because again, we've triggered a response. We've reduced the pain a little bit now, but tomorrow should start, the tissue should begin a little stronger. So like, if I see somebody in the first session, you know, they're at like a 6 or 8 out of, on the intensity, as their tissue gets more and more resilient, more healthier, I keep having to set my forces higher and higher. That's another way that I know somebody is getting better. If you come in today and you're at 6 out of 20, and then next treatment you're at 10 out of 20, and the next treatment you're at 14 out of 20, and then I'm treating you 20 out of 20 out of 20. Like, I know I've taken the tissue up, it's very stress tolerant. If I treat you today at 6, and then we get to 8, and then you went and started, let's say, doing some sport activity, and then you re-injure it, that number's probably gonna come down to a 5, a 6. Oh, sorry. So the number and the settings give me, again, indication of the effectiveness of my treatment. I don't know that there's any studies that talk about that. This is just experience. As tissue is healing, I'm using higher and higher and higher forces, higher settings. My frequency doesn't change, just the intensity. Does that make sense?
Mm.
Okay. All right.
If I don't have improvement in the next week, what's the solution?
I mean, I think you have a lot going on. So I'd be very honest that like, I don't want to leave you with the impression, oh, it's magically better. You have not had like a full thorough evaluation. And you have an acute injury on one side. So like, I would not be very professional if I made promises that I can't really substantiate. You know, would I like you to feel a little bit different? Yes, perhaps. I think it should improve a little bit, but I'd be more concerned about you getting healed from your car accident and then really having a good sort of biomechanical therapy assessment. Tightness in the hips, weakness in the hips, you know, what are the soft tissue factors that may be affecting your mechanics when you're walking, and addressing appropriate tightnesses, weaknesses. And then really this is just a part of that treatment program. Orthotics, I know the literature is somewhat, depends on if you read podiatry versus therapy. I still find that like a off-the-shelf good arch support from the pharmacy or whatnot is a very good adjunct for self-care when somebody has heel pain, because it just distributes the load and the forces directly off of the heel and over the surface area of the arch a little bit more. But I look at orthotics are a lot like a neck brace after a whiplash. Like, we don't walk around the rest of our life with a neck brace on. We just use it for a short time to get through that pain. And that's how I would look at arch supports for somebody like you. Because you're young, healthy, strong, you'll get better. Okay.
Anybody else? Do you have a question?
Yeah.
Yeah.
Hi, I'm Mohammed Ashraf. I'm a Critical Service. First, I would like to thank you for this valuable session. Second, I have a question about Calcanean spur. Many patients يعني came for us with calcaneal spur from orthopedic department. They have expectation about we will break the spur. How we can discuss or explain for them that we will not that.
Yeah, so when the heel pain is directly because of a calcaneal spur, I mean, I tell people that musculoskeletal injuries, they're sort of broken down into 3 buckets, right? Number 1 is it a dosage thing? So are you running are you running 200 kilometers, a week? It's like, are you working 14-hour days? Like, is there something that you can modify their load or their stress, and that takes away the pain? Okay, that's one. The second is it structural? All right, does it require a surgeon to go modify bone? I can't fix that. If it's soft tissue related, musculoskeletal soft tissue, fascia, muscle, tendon, bone, ligament, something like that, that responds to stretching, strengthening, then that's me. In the case of heel spurs, if they've had it and it's chronic long enough to where the heel spur has calcified and begun to encroach further into that plantar fascia, I can't necessarily make the heel spur go away. Now, there are some studies when we look at like calcific tendinopathy of the shoulder. There is some mild to moderate success that you may or could have through really high settings. Like you would have to use very high stress settings on that heel spur, and you might reduce it a little bit, but there's not a lot of evidence that would say it's effective. Like, would I try it for a few sessions and see if I could make improvements? Absolutely. But I'd be careful about like making, oh yes, I use shockwave and I'll reduce your heel spur. That's a little.
The patient came with high expectation. They think they will see that in X-ray.
There is a wrong perception that you can destroy it like when you destroy a kidney stone with the shockwave, that you are going to kick it until it breaks down. But I don't think this ever happened.
There's not a lot of evidence that I'm aware of that I can point you to this study or that study. I would simply say that you would have to use, again, very high settings on here in an effort to try to break down a bone. But in doing so, what oftentimes happens is you're creating more stress at the tenoperiosteal junction in that particular case, where you cause more bleeding in that area, and that more bleeding leads to laying down more bone. So I would only try like 1 or 2 sessions and see, if they got relief, then great. But I wouldn't feel super confident when it is a true ossification, of extension of that heel spur. Calcific tendinopathies are different. So like when the tendon calcifies up in the shoulder, there are a lot of studies that do show that focus shockwave in particular is very effective for breaking up those calcifications. For the type of heel spur that you're referring to, those are more of a high energy shockwave, and those are typically done under anesthesia by a doctor in an OR. Like that's like an ossitron or like a very high energy. This is low energy. Like I can't do damage to somebody. To break up a heel spur, I would contact Dr. Imam and he would do a 10 jet. I mean, the 10 jet that's something that's done by a physician. It's a high pressure jet of water that is actually eroding the bone. I just would be careful about making promises. I'd try it, but I'd be careful about making promises.
But the message is that you can try for 1 or 2 sessions,
Yeah.
not more.
Yeah.
Don't continue trying for 10 sessions
Yeah.
or
انا مش بتكلم عليا ان انا عندي اعتقاد ان انا ممكن اكسر الكاكينيا سبير، انا بتكلم ان ممكن العيان بيبقى جاي لي هو عنده اعتقاد ان ده ممكن يحصل.
ايوه، ما انا عارف ان الاعتقاد ده مش عند الثيرابيست او عند الدكاتره او عند المرضى.
بالظبط، فانا بتكلم ازاي ممكن يعني العيان برضه يبقى عايز اللي هو ايه، انا جاي اكس راي وشايف ان فيها شوكه موجوده زي ما هو بيتقال له، فهو جاي عنده اعتقاد ان انا بعد كام سيشن ان انا لما اجي ابص على الاكس راي الاقي ان الشوكه دي راحت.
هو الريكومنديشن ان انت تجرب سيشن او 2 وبعدين لو ما لقيتش تحسن قول لا ده مش هينفع، ارجع للدكتور، ما تحاولش تكمل معاه اكتر من كده. I was telling that you don't continue.
بس انا شايفه ان انا اقنع المريض ان هو جاي علشان يعالج السيمتوم بتاعت المشكله، مش جاي احل له مشكله الكاكينيا سبير نفسها، انا مش بشيلها، انا بعالج السيمتومز اللي عندك. My goal is to treat the symptom.
Yes, but if you tried for a couple of sessions and
I
you
don't
didn't.
even try. أنا بقول له you have to convince your patient you will leave pain free, not bone free.
Yes, the patient is the most important thing for the patient to get relief, not to
see
for
change
the
of the
spirit to
X-ray.
vanish from the
Yes.
X-ray. So if he got relief, he will be happy.
Yes.
But what Ken said that you can try for 1 or 2 sessions, not more, because sometimes under the pressure of the patient, you will continue trying with him for several sessions, but this is not recommended.
No, not if it's like if it's a true bone spur. Now, again, symptomatically, if I'm getting a response from them and they're feeling better from it, I can't say that, oh, I'm reducing that bone spur.
No,
I'm changing the soft tissue. I'm changing something.
I'm getting you better.
Correct.
Just a
So that's why I wouldn't make a promise that I'm going to reduce your bone spur. I'm going to try to reduce your pain and help improve your function. Because that's what I believe I can do. And by addressing soft tissue issues that may be in the plantar surface of the foot or that are coming, if I'm getting stress on the plantar fascia because I don't have a good ankle rocker or foot rocker motion, if I can make you move better proximally, maybe distally at the fascia, it gets relieved. So I think I'm just trying to be sensitive of the wording that I will not reduce your heel spur, but I'll try to reduce your pain. If I'm not successful in a couple sessions of seeing it reduce, I'm not going to keep going trying to reduce your heel spur. I think we're saying the same thing.
Yes.
But I try to say I'm going to try to address your pain, but I'm also going to try to explain why I'm successful, when I'm successful.
And yeah, you have a question?
I think one of the most important advices for the patient to change the footwear, to be more supportive, to be
Absolutely.
more flexible. It will add a lot in the effect of shockwave.
I completely agree. Yeah, I mean, we look at somebody's footwear, and if they're wearing a very stiff shoe, a lot of athletes, we one of our football teams locally was having a lot of issues. I was seeing a lot of their players with Achilles tendon problems because the soccer boot or the football boot was so stiff, their foot wasn't, they had no toe motion. It was all coming from the Achilles. So I actually would take a tool and cut the bottom of their cleat so that the foot could bend more, and they did well. So yeah, I agree. I think it's part of looking at all of the possibilities that are contributing to it. Is it weakness? Is it tightness? Is it equipment? Is it loading? There's so many different things that factor in. So yeah, I agree.
Any more questions?
In case of adhesive capsulitis, some expertise say that effect, and some expertise say it's not enough. Are you on it? No, you're going to be.
So again, I think that different treatments will have limited effect. There's a lot of disagreement on what exactly adhesive capsulitis is or what it is coming from. I mean, we know that it's a very painful condition and it's limiting emotion. I take the approach of I try to inflict as little pain as possible to get maximum results. So I like pairing with TechR therapy because TechR therapy is going to provide a nice heat. It's going to soften the tissue that I'm about to try to stretch. I think if I was trying to treat an adhesive capsulitis and I have my patient laying on the table and I'm just treating them here, I'm probably not going to have a whole lot of success with it because the tissue's not under any real stretch. So for me, if I was going to treat an adhesive capsulitis, I'm going to try to get them supine with the arm abducted, and I'm going to try to work into external rotation and work all along the pec, make sure that the pec minor's clear, and then I can get in, and there's nothing that can get into the shoulder joint as good as the focused shock wave. So I first start to work on the front and get a little bit of mobility here, then I can get them hopefully some posterior stress in the capsule, come onto a sideline position, and then I can work the posterior capsule as well. And then do my manual therapy and go on from there. With the technology that's out there today, I don't see any need for taking in, like cranking on someone in this super unpleasant, painful way. I think the tools make it so much better. There's not a lot of, again, in the meta-analysis side of things, I didn't see a whole lot of meta-analysis regarding frozen shoulder. Now, I keep talking about Dr. Imam, and this is why we are such a good team, is if I'm not having good success, and I had a patient with an adhesive capsulitis, and while I got her, I'd say 50% better, it just, you hit a point of plateau. And that's like as far as I could get. I sent her to him, and he does what's called hydrodilation. So he takes and injects saline into the shoulder capsule and stretches it from the inside. It was beautiful. The patient was like remarkably better in one session. So I try to know what I can do and where I need to turn over to him.
Any more questions? Anybody else would like to try? We recommend that if you don't have the device yourself, it's better to feel it.
So I would pretend to be having a presentation.
So do we want to keep everybody, or we could just try the people that want to try? I know it's a day off.
Yeah. Yeah, we keep it up to them. هو كان بيقول لو حد عايز يمشي يعني اتفضلوا بس لا يعني you are most welcome. خليكوا قاعدين لو عايزين بس.
Yeah, most welcome to stay, but like I won't be offended if it's your day off. So if you would like to feel it, I'll work with everybody that wants to have work.
احنا كويس عندنا ريل بيشنت نازل كمان ربع ساعه.
هنا they will bring a real case, a patient. But what's the case? What's the injury?
هعرف بالظبط يجيب الفايل.
Okay. You bring the file before taking the patient just to show a real case. You accept it or you feel?
I'm not comfortable in it. I don't think it. I mean, it's fine. I just would like
The
to know
nice
what-
setup.
Yeah, this is not really
Yeah.
clinical. It's, so I'm going to use a frequency of 8 because it's shallow. And then we'll start with a setting of 5.
مش اول مره يتسكر عشان كمان مش كلينيكال سيت اب يعني نايم على ترابيزه ماشي يعني لو هو موافق
هو اعرف بس هو ايه اسبوعين بلاش.
So you have medial nerve pain?
كام؟ دي mind if they approach to see what you are doing?
Oh no, yeah, come
لو
on.
عايزين تقربوا يا جماعه
يعني
عشان
في الناحية
تشوفوا
التانية.
ممكن تقربوا.
ممكن الناحية التانية. أيوة turn around.
You have to sit on this one. So what am I treating with this? What do you, I'm not sure.
I was pretending here.
Oh, you
My
pretend.
actual, okay, my actual pain is
Oh, so you're
medium
saying-
nerve. I used to have a history of injury.
Okay. But right now, do you have anything?
No.
Oh, okay. Gotcha. So we're just feeling.
Yes, I just want to make sure.
I just want to make sure I know my
I told you
expectations.
at the
Fix
start,
him.
but I think we shouldn't do that.
No, I heard it, but then I thought it moved into something else. So you can just rest. So again, right now, you don't really feel much energy right now. We're not.
Can you turn it around the way that one?
Stay on me. There you go. There you go.
Now it's pencil.
Feel it pretty good. It's like a toothache kind of feeling.
I can integrate my pain as great. Or by it's painful.
Yeah. So again, the big difference is like when we come off it, so like this is healthy
It's
tissue.
normal to have pain when I have
No, it's pretty normal. Because right there, I'm close to the periosteum and the tenoperiosteal junction of the extensor epithelial brevis, which is a stress tissue. But when I'm over sort of the softness of everything here, you don't feel anything.
No.
You don't
That's
increase
really-
Yeah.
No, I think we're fine. But you get a sense, like, when we find the lesion on the patient, it usually is that kind of an feeling.
Okay.
You know, it's where tissue is stressed. Tissue, like we all have, like some here. Wherever we have tissue stress, we're going to carry with us some minimal amounts of inflammation in our body at all times. So that's why we get some reactivity there, because that tissue is always under a bit of a stress. Every time you grip your hands, this is working to stabilize. So like, there's common points that I'll find, whether it's in the knee, in the foot, because our bodies are under stress all day long. That's that whole concept of the envelope of function. Our bodies are used to being stress tolerant, but when we overload it and we take it too far, we use this to just kind of help bring it back in. Stress the tissue, the body releases more focused protein, makes the tissue more stress tolerant, and inflammation will go down. Yeah?
Thank you.
Who else would like to try?
Just do your
And as we agreed earlier, we will avoid using ice packs after shock, so?
I do, yeah. I mean, I'm sure there's somebody out there that's gonna say do it. It's just my preference to not. Maybe turn that off. Maybe just-
I wanna play watches first, I feel pain in my shoulder.
Oh, you wanna take off your shirt? Okay. So it's your left shoulder. Where do you have pain? Where?
In a complex
In the AC joint?
yes, I do feel
Okay.
and we get not straight off.
طيب انا حكم
I avoid watches because I feel pain, still feel pain when I take watches first.
Have you sprained that joint? Like, have you ever had an injury to that shoulder? Like fallen on it and popped it?
Yes.
So
some
it has,
when I temporary watches first in gym.
keep this arm.
طلع ايدك طلع ايدك فوق.
There you
What is the case?
What does he suffering from?
With what chest passenger.
Well, change this.
Which one?
Pain must be more like right there.
You just wash the gel patches. And you,
Alright, look at that one. And I'll hit it really good.
it's a fine.
شفت الفكرة ازاي؟ شفت مستر بقى فين الشغل.
So, can you raise your arm up and down right now? If you do,
Yes.
good. If you were to do like a push-up, there,
But just
there.
yes, I feel very, I can't do it.
But you feel pain right now if you did that.
In first, no.
Okay. Here it's a 15.
Alright, I'm gonna use it in a second.
Start with the fine.
Right there.
There's no position? There's no position? Just in this position?
This it's not my favorite. I prefer to have him on a table where I could control him here.
This is what you're asking about, just moving shoulder in this position during the session.
Yeah, we'll try some motion in that. In 0 to 10. Let's just hang out here for a second.
Increase. Knowledge.
تكسرته ازاي؟
Number one rule, never drop your therapy source, because it will crack the head. If this was in our clinic, somebody would drop it, break it, and then they put it back until I find it. And then I'm like, who broke this? I don't know.
The ghost
Nobody-
came after we left. and
Nobody
then-
knows. Yeah, it was the cleaning.
Fights at the door
You know, there is always a ghost in every clinic.
during the night.
Yeah.
Yeah. Very okay.
الآن ألف في نفس النقطة.
This is your next album. Don't do anything. Just let it be. do the motion.
Okay.
Is moving with the shockwave give more benefit?
Yeah, because now I'm getting tissue as it lengthens. I'm maybe finding places that I wouldn't otherwise have known.
With either focus or radial?
It's harder to do with focused. I'm sorry, it's harder to do with radial. But I would do the same with both. Yeah. I definitely want to increase your intensity. Try that. Just take it through full motion.
Try the push.
ومع المقاومة لو في مقاومة ببدأ أحس بقى إيه أنا كده عادي مفيش. على الجهاز بقى بتاع اللي هو تشيست بريس ببدأ إن هو إيه بحس
قبل السيشن
لا
حاسس
بحس كان بيبقى في موفينج كده.
So that was the shallow. Now we'll take in.
deeper.
So let's go on to. Let's move this out and let's go on to your hands and knees. Yep. We're gonna. So I'm gonna come down into this position. Come. Up here. And try to. So now I'm gonna hit the posterior part of the capsule. Just relax. There you go. So here I have the body weight pushing on the tissue. Do you have any pain right now? Note to self, I'm going to do that. So I'm just backing this down. You feel it? Is that uncomfortable? Oh yeah, absolutely.
مش عارف بس عارف كل
So here, because I'm rock. Yep. So kind of. No. Bring your arms up and just sort of rock. Yeah, there you go.
So we are going to the 4,000 now. So
It's front and back. Yeah, that's front and back. So 4,000.
So that is 2002
separate.
Yeah, separate. كده المرة دي مع جلستين ولا جلسة؟
I'll try that movement. Oh, fix your shirt. Right. How's it? Yep.
I'll figure it out.
Anybody else would like to try?
There. There. How to draw?
Any questions?
In case of tear, the substance tear, partial tear, not complete tear, there is no problem to work with the focus shockwave?
So that's a good question. I mean, if there's a partial tear or a full tear, would you say?
Partial tear.
I think partial tear can be helpful because we want to find out, well, first understand why, like if they fell or something like that. When there's a partial tear, I probably would not, again, because from a chronic condition, if it's an acute tear or chronic tear, do you know?
I think maybe the patient help us after the chronic condition, like the osteoarthritis of the acromioclavicular joint. In this situation, the case was bursitis, partial tear after.
Anytime there's a partial tear, I probably wouldn't go like full power. I would ease into their level of discomfort. Kind of like we were talking before, I'd probably come in 2 to 4, is that okay, first treatment, and just see how they do with it. Now, I've had patients that have had shoulder pain, and they come in, like they didn't have any imaging, so we didn't know whether they have full tear or not. You know, they have some clinical signs and symptoms, but still people can mask some things. If I do a shockwave treatment and it does nothing for their pain, as I said, I look at, there's gotta be something else going on. So I've had patients come in where they had pain, I treated their rotator cuff, and they continued to have pain. We then later find out it was like a torn rotator cuff or something bad. Now on a partial tear though, this can be helpful for collagen remodeling, so like we'll work through their motion, but I'm not gonna go very high with the pain thresholds because like I just want to nudge the tissue along so that it heals. I don't want to blast it like it's a stiffness or a tightness. If tissue is stiff or tight, I'll use a very high setting.
So we're working like a 5 to 6 between these numbers, right?
Yeah, nothing higher.
Nothing higher.
I would probably start at like a 2 to 4
2 to 4.
and see how they did there on their first treatment. If they come back to me and say, you know, yeah, I felt great, I might go 4 to 5.
Maximum 5.
Yeah, probably.
Okay.
And then supporting it with all the other things that we know to do. So if it's something in the back, I'm always going to work in the front. If it's something in the front, I'm going to work on the back as well, because the shoulders, they get you from both directions.
Okay.
So with the rotator, with a partial tear, I would make sure I'm addressing pec minor and anterior capsule, as well as trying to work on targeting the posterior capsule. And you can get that in a lot of different ways. Like I'll position a patient on sideline, have them put their hand on the table, and then I'll kind of manipulate their elbow. So I'm on my side. I'm manipulating the elbow so I can kind of find that spot in the posterior inferior capsule. And sometimes I'm hitting down in here. And that they usually feel really good.
There's another question about the bone healing after the bone fracture. They say that shockwave is very good for the bone.
Same thing I use with that, with bone healing. It is very good for stress fractures and things like that, but again, but we're introducing more stress. And so we want to be careful. Like, I'm not going to go to a 5, 6 out of 10 pain.
2, 3.
Exactly.
2, 3 max.
Just like right at threshold.
Okay.
As soon as they feel some discomfort, that's all I will do.
We give them 2, 3, maximum 2,000 shots.
Yeah.
That's one good. The last question. I know.
I think you said that like 3 questions ago.
I asked all 15 questions.
It's okay.
Okay, this is the 16. The same session, can I use the high power laser with the shockwave?
Absolutely.
There's no
I
conflict
love
with
it.
them.
Yeah, because if you think about it, we're doing this whole physiological
Yeah.
cascade
Yeah.
in order to get the body to send more blood, send more inflammatory factors to try to manage the trauma that you just caused.
Mm.
The best thing that you can do, and the studies looking at, when do we sequence laser? Years ago, I used to put laser at the front end because I thought, I'm getting heat and that's a good thing to do. But now more studies are showing that laser is much better when done at the very end of treatment. Because, Mhm. Because it's at the end of treatment, like you've done your exercise, you've done your soft tissue work. All of these things that are now, they need energy to continue that process. You do laser at the end, and that's what I
So it's better to start with the shockwave and end with the laser.
absolutely. That's exactly what I would do.
No question.
In the case of knee osteoarthritis, shockwave can be useful.
Yes, absolutely. So like with an arthritic knee, I'll start usually. I'll have the patient just seated on the table, like with their leg hanging down, and I'll sit on the stool. And because when the knee is bent, it's exposed, and I can get in there. So first treatment, I can look at their face, I can see and read if they're having discomfort. But I know the areas where they're going to be very sensitive is going to be medial tibial plateau, usually. I can come down and do some work on the patellar tendon. And then I'll come up almost always where the IT band inserts. That's always a little bit tight. And so I'll hit that area and then come around into the medial femoral condyle, and I can also shoot down into the trochlear groove here. So I kind of check all the different areas in the front of the knee. And then if that's okay, in their second treatment, I'll probably put them on their back, because then I can start to progressively get the knee to bend more. And do all kind of the same thing, but I just kind of work that whole area. The arthritic knee does, really pretty well. And there are some studies showing, this is more basic science, not like clinical studies, but basic science studies looking at stress and shock induced increases chondrocyte activity as well. But I get very cautious in that it's not growing new cartilage. It makes the chondrocytes a bit more resilient, and it does increase their activity. But the same thing happens when you walk or when you stress the joint. A little bit of stress is a good thing. We're trying to give it the right stress, a safe stress. So again, carpal tunnel, you have to make sure that, is that coming truly from the carpal tunnel or is it coming from the neck? So if you, let's say you cleared the cervical spine and you've isolated it just to the wrist, I'll hold the so I'll hold the hand here so I can use my thumb to create a little bit of a stretch. And then I've got the sound head there. So that way I can open things up and create a little bit of stress. I can also close it, and when the tissue's soft, I can get into a little bit deeper there, it's usually less painful. And then we'll stretch it again as we bring it into some more extension.
Okay.
Working gradually also. Working gradually from
Yeah, like
5
just
to
kind of
8
common sense.
to 10.
Absolutely.
Okay.
Anything in the wrist and
So,
hand.
it will be useful.
Yeah.
Even the retail will have?
Even
The focused only or the retail also?
the radio will hurt like hell.
Nice.
I mean,
I
so
tried.
Yeah.
I mean,
So you experience the
want-
pain, yeah.
if you want somebody taking a hammer and hammering at your carpal
عشان
tunnel,
كده في الأول يعني قلت له على I told you earlier I have a carpal tunnel but I wasn't so excited for you to try it عشان
Oh, I mean, we can try it. I mean,
no don't bother يعني
it's
we'll have
She's
to
still
take it
scared
easy.
from the last time.
Like a traumatic
But if it was a double crush from cervical and carpal tunnel, I should work on the course of median nerve.
I would work the course of median nerve starting at the cervical. Depends on, I guess, what was the original pain generator, but yeah, and doing your like nerve flossing, so you're trying to get the nerve to glide. And so, again, if you find where the sticking point is, then I'm going to work more in that area to try to free up. So, I mean, depending on where you're at with like neurodynamics, I don't do a lot of that, but I would try having them do their their flossing technique while you're actually applying the shockwave. Oh, you're ready to go.
almost دي العلاجية التانية كانت تجربة
Bump that up. The frequency.
it is painful.
Turn it down to 1. 1, yeah.
كده one
That's the one.
it feels like
Feels better.
this one really hurts no that down down
So how about if we use a short now?
it gives me sensation and numbness and all my favorite
How about in this position?
much better much harder yes this is more I should do it with more
I'm trying to see if I can if I can get the nerve.
now it's okay thank you I would say search for a paper.
I mean, I try to find a painful point. I'm not going to tell you. So I find a painful point, and I'm going to try to work off it a little bit.
مش شغالين على كل
There are
الوقت
other areas that might
بس هو
I wouldn't a little.
What about the pain now?
ما يعني بتعذب من بتعذب
Pain only move?
a little bit pain when I move this neighborhood structures مثلا زي
جينا عندنا ولا جينا عندنا
بس يا دكتور والله دي حاجه كويسه.
نفس الفكره بس ده الايباد بيوريك بس وبعدين انت بتوصل سنه مش شايفك مش هتدخل في ترانسفير
Can you say that louder?
انا بقول له البوينت دي was scaring me earlier بس دلوقتي تقريبا انا مش حاسه باي حاجه، احنا عمالين نرغي اصلا مش حاسه باي حاجه. لا خليك تشرح لي، انا دلوقتي فعلا مش حاسه بحاجه. لا هي ايوه لا هو انا مش حاسه بالجهاز فعلا يعني في الاول انا مش قادره.
Again, we started at 3, that was too high, so we backed down and you find a place where I can work. You know, you want it to be comfortable, because like I could tell, she was like, all right, this is not pleasant.
Thank you.
And in order for me to have effect, I need to deliver the treatment. So I've got to find a way to get through it. So I'll typically try, if a 3 or a 4 out of 20 is too high, I try to drop it by 50%. And can we get more treatment done? And we did. And then I back off, but then later on I'm able to increase it back.
We started at ended at 2 months, huh?
No,
We started
yes,
at
3.
We started at 3.
1 3 3 1 3
كويس.
هو طالع نازل على حسب
Can I ask a question? PiezoWave pain, how can apply and the parameters?
Low back pain, it's a whole nother ball. You know, the evidence shows that yes, shockwave is very effective for low back pain. But again, understanding why they have low back pain is really the question. You know, is it because of a mobility issue? Like that part you would need to sort of determine. For back patients, I like doing them in the quadruped position because they can kind of get into the child's pose, you know, and I can get some traction. So if it is like a tightness, like somebody's really hyperextended, you know, it can be very effective. If it's an SI joint that's causing the low back pain, again, this is very good for preparing the SI joint for mobilization. Again, low back pain, I try to take sort of the least complicated pathway. So it's not something I would typically introduce on my first session until I've understood, like, really why were they having back pain. Back pain could be because they have tight hip flexors, they could have tight hamstrings. I have to figure out what's contributing to the back pain and then address that. But just shooting the shockwave into somebody's back pain, I think you have limited success with it.
In case of hypermobility,
Case of hypermobility, hypo, then yes, if you have like a hypomobile segment, then blast away. That's where then, if it's a hypomobility, then I'm usually going into child's pose, trying to get some distraction or tension on the facets, and then aiming toward the center of the spine in order to deliver the shocks down into the
paraspinal or central?
Paraspinal. So like if this is the spinous process, I'm not coming over it, I'm coming this way at it. So I'm shooting down into the paraspinals that are running along there.
Doctor, you mentioned earlier about coccydynia.
Coccydynia. It's great for coccydynia. Just because again, depending on the cause of it.
It is inverted most of the times. It's inverted.
So getting in and working all of that soft tissue that connects to, it's not so much the coccyx itself, but it's all the soft tissue that's coming in to insert on it. So working
On soft tissue around it.
the soft tissue around it, and then if you're like going in to manipulate it, it just makes moving things around better. But it's generally addressing the soft tissue that's coming in and inserting, and the fascia that all connects there. So
Because I have
again,
a case.
oh, do you?
Yes.
So
I
like,
have a patient that suffers from PCD.
and was it as a result of a fall, or do you know what was the trauma
No,
that
it's not full.
idiopathic? Or?
Yes.
I mean,
And
it's
she
always
doesn't tolerate any pressure on the glutes and her back. So I asked her this.
so again, one of the best positions I think, working in quadruped with patients, as long as they have the hip and knee mobility, which is important, but being able to get down into that child's pose where you can then really kind of work along where the gluteal crease and cleft starts, and I would work like that whole area. So like the inferior portion of your lower lumbar fascia is all coming down
Yes.
and attaching on there. So I would first start kind of rounding out on the top of the buttocks, and then working up to the top side of the diamond.
And first use this, then manipulation of coccyx.
Yeah, I would start with this first, absolutely.
Last question. You previously mentioned partial tear potato cuff. Can you use it in complete tear?
I don't. I'm not sure what the objective would be. If it's like pain management, I would use it more for trying to like loosen up the capsule. So because if it's torn, then they're going to be coming kind of more anterior if they're chronic. So you run greater risk of having, a subsequent eventual biceps tendinopathy or something there. So I'm probably going to try to treat a little bit anteriorly, but then bring them back into that inferior position. So then I can come and try to mobilize them posterior. I mean, it's one of those things, I would start trying anything if they have a complete tear, because I'm not going to fix the tear. I'm going to try to address the symptoms or the consequences of the tear, but I'm not going to fix the tear. Especially if it's torn, and most likely it's retracted at that point. Yeah, you're kind of stuck.
So in each area I should put tension or stretch on it before I do shockwave?
A little bit. I mean, I'd position for some tension because you're going to get a more effective shockwave treatment if you position with tension. Now, and I'm sorry for your name. Khadijah. In the case of Khadijah, when I had her in stretch and I was trying in here, she didn't really like it that much. So I brought her in a little bit and worked in more of a neutral position as opposed to a stretch. My goal is always going to be to get to a stretch, but if somebody can't tolerate it, then just take some tension off. And again, you want to find the permittivity of the patient and their tissue, because we all have to come together and be in agreement. And if somebody's in a lot of pain, that's not agreement. So in the case of any patient, whether it's a rotator cuff tear or I would try to figure out what is it that I'm really trying to do to help this patient.
Neovascularization.
Yeah, I mean, neovascularization is part of it. But I mean, if it's torn, it's torn, right? I'm not gonna.
I think the message you are trying to deliver, it will never repair the complete tear. Yeah, that's you have to keep in mind. It will never repair
Partial
it.
maybe. Yes, because it's partial. It's possible. But you have to, there's a lot of other things you have to address. Because if it's a repetitive activity, and then you could do the most wonderful treatment, but then they go and stretch it again, it's gonna have a hard time healing. You'd have to sort of have a period, you have to have some immobilization, I would think, to protect that, so that they could kind of knit back together. That's where, again, going back to Dr. Imam, PRP is very helpful, because we can then immobilize them a little bit, put them into a shoulder sling, PRP them, and PRP will turbocharge that healing process, because it's all of your inflammatory.
Will work with complete third?
Not complete. I'm not saying complete, incomplete.
Even
Thank you.
even if after reconstruction, I can use my
After reconstruction, absolutely. I love it after reconstruction.
box. You can use it.
I would say once a surgeon has cleared you for mobilization, then I would use it. I mean, theoretically, I would use it much earlier, because I'm not worried about it. But I also know, so, unless you work hand in hand with a surgeon and he says, yeah, no, that's cool, I wouldn't do it. If their protocol says no movement for 6 weeks, I'm not moving them for 6 weeks, unless I have some sort of agreement with them. Now, I do have a shoulder surgeon that I have agreement with, and I will do post-operatively. I love doing shockwave, because I know they're not moving it. Their tissue needs some sort of stimulus or stress if it's going to get stronger. I'm just not going to use high stress.
Low.
It's going to be very low. So, like, if I'm moving around and they're like, I feel it right there, I'm just going to back it down a little bit. Because I just want to give it, like, it's like giving it a little hug in order to heal. I don't want to punch it. I want tissue to be happy. Unless it's really misbehaving, then I'm going to punch it. Those are great questions. Good questions.
Yeah, I think it was a very nice session. Everyone is happy? Yes. It's the most important.
Again, thank you, shukran, for being here, and I hope to see you again, inshallah.